We looked at CDC recommendations for appropriate pre-exposure prophylaxis in patients at risk for exposure to HIV, and then given an HIV-exposed patient, we recommended appropriate post-exposure prophylaxis regimen. Now, given an HIV patient case, evaluate and manage common drug-drug interactions.
So when it comes to the pharmacokinetic boosters, we have Cobicistat and Ritonavir. Cobicistat is actually not an HIV drug, so it has no activity against HIV. Ritonavir itself is a HIV protease inhibitor. However, we actually don't use it for its protease inhibition because we use a lower dose. It's such a potent inhibitor of these enzymes that we actually use it at suboptimal doses. So the doses, 100 milligram of ritonavir is not enough to be active against HIV, but 100 milligram is such a potent inhibitor of these enzymes that we actually use it to boost the concentrations of other protease inhibitors. So you can see there are some differences between the two. One thing in particular about Cobicistat is that it can actually artificially increase serum creatinine, and that's because it actually inhibits some of the secretion of serum creatinine. So it really does nothing to the GFR. So, obviously integrase strand transfer inhibitors are primarily the first-line agents that we use for treatment of HIV. So currently we have 4 on the market: raltegravir, dolutegravir, elvitegravir, and bictegravir. Elvitegravir is the only one that needs to be taken with food. They're pretty much all taken daily. Up until recently, raltegravir had to be taken twice a day, but now there's a new higher dose of it that you can actually take once a day. In particular, elvitegravir and bictegravir are actually substrates of 3A4. So elvitegravir itself actually needs to be boosted. So Cobicistat will inhibit CYP3A4. So as a result, you will need less of elvitegravir. So the pills will be smaller, and also with the half-life that's a little shorter, 13 hours, you can still dose elvitegravir once a day because of that pharmacokinetic booster. Now, bictegravir, although it is a substrate of 3A4, it does not need boosting. So, you need smaller doses of bictegravir, so 50 milligrams. So also the pill is smaller than elvitegravir. So that's another reason that boosting was not needed for bictegravir, because for 50 milligrams the pill was small enough, whereas elvitegravir, even with a booster, you still need 150 milligrams. So if you didn't have that booster, you would probably need several times 150 milligram. So when it comes to drug interactions, elvitegravir will have the most, not because of elvitegravir itself, but because it has to come with Cobicistat. So Cobicistat will cause a lot of drug interactions, whereas the rest of them don't have a pharmacokinetic booster. One thing that bictegravir and dolutegravir have in common is that they both inhibit OCT2. And one thing that's important is metformin is actually a substrate of OCT2. So OCT2 is it's actually its function is to actually secrete metformin. So because they inhibit, you will see metformin levels increased. So that would be a significant drug interaction, because you will see a lot of diabetic patients on metformin. Bictegravir also inhibits MATE1. So let's look at some clinically significant drug interaction. So all integrase strand transfer inhibitors will interact with cations like antacids. So any polyvalent cation containing like aluminum or calcium, they will actually bind to integrase inhibitors and will prevent their absorption. So for that reason, anything that contains a polyvalent cation should be avoided, or actually should be spaced out by 2 hours. So 2 hours before or after you give integrase strand transfer inhibitors. So all 4 of them will interact with antacids, or not just antacids, anything that has. So if you were giving calcium pills or anything that has a polyvalent cation. One thing that bictegravir and dolutegravir have in common is that they both will interact with metformin and dofetilide. So when it says avoid, when I say avoid, I actually mean contraindicated. So dofetilide is actually contraindicated with bictegravir and dolutegravir. Metformin is not a contraindication, so you just adjust the dose. Now, there's a really good chance that Cobicistat may also interact with dofetilide. However, it's not in the package insert at the moment. So they may just not have studied it, but be careful with Cobicistat and dofetilide. I didn't see it in the package insert, but I suspect Cobicistat will also interact with dofetilide. Bictegravir is also contraindicated with rifampin because rifampin is a strong inducer of CYP3A4 and bictegravir is a substrate, so rifampin should be avoided. With elvitegravir, it's recommended to avoid anything that's a substrate of CYP3A4, like these statins are actually substrates of CYP3A4, and because Cobicistat is a strong inhibitor, it's actually contraindicated to use these two. It is okay to use atorvastatin. The same goes with salmeterol. And then rifampin, of course, is a strong inducer of CYP3A4. That actually, because you actually need a pharmacokinetic booster for elvitegravir, so Cobicistat is a strong inhibitor of CYP3A4, and rifampin is a strong inducer. So you should it's actually contraindicated to use rifampin because it will mess up elvitegravir levels. The same with some of the anticonvulsants like phenytoin. They're also inducers, so pretty much most inducers of CYP3A4 should not be used with elvitegravir because it needs help from a pharmacokinetic booster. And then, of course, because of Cobicistat, patients use caution with hormonal contraceptives because Cobicistat can inhibit and cause failure of hormonal contraceptives. When it comes to protease inhibitor, of course, these are the three most common protease inhibitors, and of course they're boosted. And the reason they can be boosted is because they're all substrates of 3A4, so they're not usually renally cleared. And for non-nukes, so efavirenz and rilpivirine are the two common ones that you use. Etravirenz actually, for food, you should take it after each meal. Food can actually increase etravirenz by 50%, so it's recommended to take it after meals. It doesn't necessarily mean empty stomach, but it just says take it after meals rather than with food. Now, these are all CYP3A4 substrates. One thing that's special about efavirenz is that it's actually an inducer of CYP3A4. So you will also see a lot of drug interactions with efavirenz. So for protease inhibitors here and rilpivirine, here are some clinically significant drug interactions. So again, because protease inhibitors are boosted, you should avoid substrates of CYP3A4. So here are the three statins that are substrates of CYP3A4. Atorvastatin also has a separate mechanism of clearance, so it's not as strong. So it's only listed here for because it's in the package insert for itazanavir, boosted itazanavir, but it's okay to use atorvastatin with darunavir. There are also hepatitis C protease inhibitors that are also substrates of CYP3A4, so they should be avoided because these are boosted and the boosting will affect the levels of hep C drugs. And the same can be said about salmeterol. Now, itazanavir and rilpivirine both need an acidic environment for absorption. So with itazanavir And with rilpivirine, you should actually avoid proton pump inhibitors because they need the acidic environment.
Let's take a look at some common drug interactions. When it comes to drug interactions, you will see that the majority of significant drug interactions are with boosted regimens, so either boosted protease inhibitors, so atazanavir, darunavir, and lopinavir are boosted with ritonavir or with cobicistat. And of course, elvitegravir is the only integrated strand transfer inhibitor that's boosted with cobicistat. And because these pharmacokinetic boosters are CYP enzyme inhibitors, they lead to significant drug interactions. Now, when it comes to corticosteroids, you will see that beclomethasone, which is available as both the nasal formulation as well as inhalation, is pretty much safe to take with any regimen. Now, for the sake of this discussion, we're going to ignore any topical formulations. Budesonide is available as inhaled and intranasal formulation, but it is also available as systemic formulation, so it can be taken orally. And you will see that it's contraindicated with any pharmacokinetic booster, so it's not, it should be avoided with the boosted PIs as well as elvitegravir. Now, it does interact with efavirenz because efavirenz is an inducer, but it's not really contraindicated. So you just have to monitor and make adjustments to the dose of budesonide. Now, systemic dexamethasone itself is a inducer, so it can actually reduce the concentration of protease inhibitors and elvitegravir. So it should be monitored and dose adjustments must be made. But the interaction is significant with rilpivirine, so it actually should be avoided with rilpivirine. Now, fluticasone is available as inhaled and intranasal, and both the routes are actually contraindicated with boosted PI or boosted elvitegravir. Mometasone as well is available as intranasal or inhaled formulation, and both routes are contraindicated with cobicistat and with boosted protease inhibitors. Prednisone is systemic, and it does interact, but it's not contraindicated with boosted regimens and efavirenz. Salmeterol is inhaled. While it does interact, it's not contraindicated. So anything that's yellow, it potentially interacts, but it's not contraindicated, whereas the red boxes are contraindicated and should be avoided. And the green, of course, means no significant interactions. Now, triamcinolone is also available as inhaled or intranasal. It does interact with boosted regimens and efavirenz, but it's not recommended. Of note, triamcinolone, fluticasone, and budesonide are also available over the counter as intranasal formulations. So as pharmacists, it is very important to provide education to patients who can easily walk to the shelves and grab any over-the-counter products. So if they are on these boosted regimens, it's important to let them know that fluticasone and budesonide over the counter are contraindicated, and triamcinolone would be the safer option should they need intranasal corticosteroids for seasonal allergies, for example. So that's an important education to provide to patients. Now, when it comes to some of the cardiovascular agents, of note, amlodipine and diltiazem are two commonly used calcium channel blockers. Because they are also substrates of CYP enzymes, they do interact with boosted regimens as well as efavirenz. However, they are not contraindicated, so you just have to monitor the patient's blood pressure and heart rate with diltiazem and make adjustments to the dose of amlodipine and diltiazem based on their blood pressure and heart rate. Okay, so we are here at the local Walmart. We're gonna go check out the pharmacy. You know where the pharmacy is? Okay. Okay, so I'm looking for over-the-counter allergy relief. Okay, so they have Flonase and Nasocort. Oh, Cecilia, you're here. I have a HIV patient who's taking boosted regimen. They want Flonase. What do you think?
No, that's a terrible idea. Flonase will interact with boosted regimen and non-nukes.
Oh, what should I do then?
Go this way. Nasocort.
Nasocort?
Yes.
Oh, thank you.
I'm here to help you.
When it comes to hormonal contraceptives, CYP3A4 has a role, so both efavirenz and ritonavir can affect the levels of progestins. So because of that, it is recommended to use additional contraceptive methods when the patient is actually taking efavirenz or boosted regimens. So with these, they're not really contraindications, but it's important to let the patient know that these can make hormonal contraceptives ineffective or less effective. So they should use alternative methods of contraception. So primarily with boosted and efavirenz. So as I mentioned before with statins, basically the three statins that go through CYP3A4 are listed here, but atorvastatin in particular doesn't primarily depend on 3A4. So, historically, atorvastatin was considered a drug interaction with anything that affected 3A4, but nowadays we have data that atorvastatin is not as much affected. So, the only exception is that with atazanavir, atorvastatin is actually contraindicated, but with with darunavir, for example, they just recommend the maximum dose, but it's okay to use atorvastatin with darunavir. So these two contraindicated with anything that has cobicistat or ritonavir, so anything that's boosted.